And it gives me great pleasure to introduce Dr. Umesh Kumar Roy, who's a CCG board member, innovation lead and chair for improving cardiovascular outcomes in Leicester City. Dr. Roy.
Thank you. Good morning, everyone. I hope everyone can hear me. Is that all right if you can just... Right, thank you. Right. Very quickly, my job today here is to give you some practical examples of productivity and efficiency. And my personal job role is, firstly, I'm a GP, and then I spend 2 days as a CCG board member trying to change and try to implement some of these concepts at a CCG level. And how do we then make the big word that we always talk about is productivity and efficiency. So I'll just go on to the next slide as to the problem, as to why I believe in productivity or efficiency. I mean, this is in relation to Leicester City, and just to show you this data set, all the red dots that you see on the left-hand side of that graph explains where Leicester City is in comparison to the country. I hope that is clear, but what it tells you that all the red dots that we have there to the left-hand side means we are doing very, very badly in terms of early mortality or in terms of emergency admissions related to cardiovascular. Most of my examples today are related to cardiovascular conditions. Now, if that is the problem that exists, and you know, and this is a data set that you all would probably have it for your region or your locality from public health, then you'll know where you're doing in terms of outcomes. My focus is not just on productivity, but it's also on good quality outcomes. And I'll go on to explain further how quality actually improves your productivity. But if that is the background that we have, how do we change that? I'm sure those who are GPs here in this audience will remember this phrase, the QUIP word, and it makes different kinds of understanding if you're a GP or if you're a manager. For manager, the word QUIP is all about the treasury, and you've got to deliver it. Whether it is 7% or 10%, whatever is your kind of target, is just mentioned as a number. But what I say to my GPs and colleagues is, forget the last P of the QUIP. If you concentrate on the quality, innovation, and prevention, then those 3 letters will ultimately produce the productivity that you're looking for. And I'll try and prove that concept as we go along throughout my presentation. So, what we developed in Leicester City is the 3T concept. It has to begin with recognizing that in primary care, we have wide variability of skills. So unless you upskill them, train them, they cannot implement the new challenges ahead in terms of bringing out the good outcomes that we are looking for. Attending a session or a 2-hour CPD session ultimately does not produce the cultural change or behavior. So the concept is the good old-fashioned, which is about teaching, training, and treatment. And that is how we learned as young doctors in the hospital, which is all to do with a cycle that it has to be repetitive, it has to be with the live patients, so that you get the confidence to deliver. The next slide is the same thing, which is called the experiential learning cycle, which starts from live patients and it goes around in terms of getting that repetitive training. So the moment you have a new concept, just telling to your colleagues or your primary care team will not do any change really to the patients. So we got to invest more time in actually delivering that concept. And that is very key and central to most of the pathways that I've had to try to implement and the logistics of implementation to that effect. So that basically shows what are the outcomes in terms of after getting upskilled, what are we aiming for? Of course, we are waiting for a better clinical decision. The objective is to upskill the primary care workforce, and that doesn't mean just GPs, I'm afraid. It has to be the whole team. The graph on the left-hand side actually shows you the prevalence of Leicester City GP practices of AF, or atrial fibrillation. If that graph was a bit more smoother, I would say yes, everybody would expect some amount of variability anyway, because that is the nature. But to have a kind of a graph like that, where one practice has just got one patient with a 5,000 list size, does make you wonder. So how do we change that? Once at our level, they've gone on training, I'll just stick to now the DVT pathway to begin with and then go on to AF in the end, because that is very crucial as well. DVT is a very quick pathway that we have developed in Leicester City. You know that roughly only 15 to 20% patients are positive for DVT at the end of the day when you have sent all those patients to the hospital or the community service or wherever your service belongs. For the first time, I agree with NICE, and I hope that is the NICE pathway on the right-hand side. I know it may not be very clear, but what it says essentially is that if you suspect a patient with DVT, they should be scanned in 4 hours. Can I have any person in this audience who can say that 100% of your patients with suspected DVT are scanned within 4 hours? And there you go. I don't see even one hand, because it's not even there in my CCG yet. Yes? When are we going to implement that standard? Which one of you would want to be on an anticoagulant on a suspected DVT for the next 3 days till we say, yes, you have DVT? Anyone? I doubt it. I wouldn't want an anticoagulant even for 1 hour if I didn't have DVT. So the concept is right. You need to scan within 4 hours of suspected DVT so that you can tell those patients you don't have DVT and you don't have to be on an anticoagulant. So you only put 20% of the patients. But how do you achieve that target? If everybody is going to secondary care, it's just going to be a bottleneck. So, what we devised was that every GP in Leicester City will undertake this program of learning. They will use a near-patient point of testing, D-dimer testing, and a well scoring. By using these two, you would be able to exclude 50 to 60% of DVTs that don't need to go to that center. It's quite easy to do. We developed an integrated template, so it takes you step by step. You can do the well scoring integrated within your System 1, because we use System 1 in Leicester City. Even I don't remember all the 7 questions to ask in order to score at that point in time. But if you have a prompt which is integrated, you will be able to do it quite quickly. And then the next step is you actually follow the template as to where in the pathway is the patient needs to go. And that is quite interactive in order to take you the quick and easy steps. So, this is just the slide in terms of that once you initiate the logistics, you still need to get the confidence. So what we have, patients attending the practice, but also the mentors from the bottom supporting those practices on an ongoing basis, so that that repetitive training and the cultural change takes place. Just giving them a machine and tell them to go and do it from tomorrow does not happen. Obviously, if you go on the row stand, you'll be able to see this machine, which is Kobash H232, which does the near-patient testing. It takes you no more than 7 to 8 minutes to get the results there and then. It just doesn't do the D-dimer. Our next phase on it is to do the BNP, which I'll talk to you about the heart failure in my presentation. I hope I don't run out of time, so I'll probably rush into it a bit more quicker. Well, how am I doing? But essentially, this is a machine that also does troponin T, which is the third phase that we will be implementing in our Leicester City pilot practices to then look at chest pain patients where 50% of them are atypical or musculoskeletal. So, in terms of the results of the DVT, if you look at year 2010, 11, and 12, in terms of the pound sign, we spent roughly 350,000 pounds every year. But if you look at the current year, which is 12, 13, we have reduced that costing by close to 80,000 pounds. It also means that the follow-up rate is being reduced because it is a one-stop service for those patients who have hit the hospital. They don't need to keep coming for 3 days or 4 days in order to keep getting the unnecessary anticoagulant, be it low molecular weight heparin. So, we go on to heart failure next, and that is the activity data set for Leicester City. If you can read from there, from the far end, maybe the fonts are not big enough, but what you will see is roughly year on and year on until even 12-13 on emergency heart failure admissions, we spend about 1.7 to 1.8 million pounds. And I'm talking about emergency heart failure admissions. And then we have a baseline data for each locality and then each practices and the number of patients that go into the hospital. If you look at just one practice, second row from bottom, which is one patient that costed £10,000, but on average the cost is about £4,000, and I think by and large that will be the same across the country. I don't think it would be any different because the HRG is related to complex condition, because these heart failure patients would probably have had previous hypertension, diabetes, or MI in the past. So the cost is going to be horrendous, really. So that is the problem. So what we did for that is from each practice, we got one GP to come up for a training on these areas, which is comprehensive training session, but also at the end of the training, they took an exam. Having said that, teaching and learning, at the bottom is still the mentors and continuous support is still going on. So we don't finish off with just come attend my lecture and that's it. We have regular peer review. In fact, for one of the cohort of 20 practices, I'll be doing a peer review this evening when I go back to Leicester to see what they've done in the last 2 months and how many patients they've done. So it's like a continuous monitoring and support. I call it peer pressure or peer review, whichever way you want to call it. But you've got to use all these techniques in order to create the first 3 letters of the QUIP. Objectives, obviously, is to increase the cough prevalence. That's more money for the practice, so there is income there. It is all related to a locally enhanced service. It's not a huge amount. They get paid £30 roughly. I know I've not quoted in my slide, but if you're interested, they get £30 to do this final review. So there is some money to the GP practice. So what is the pathway here? You take a good history and examination. You do the point of care testing BNP. Now the cardiologist will tell you that in fact a positive BNP is still very complex and you need to refer them all to the cardiologist. My issue is not with high BNPs, but the negative predictive value, which means if a patient has got negative BNP, you can safely say he's got no heart failure in almost 95% of the patients. And that is the important bit when patients come to you to say, yes, I'm not going to just admit you to the hospital, but look at what else you may have. In the pathway, if they have a positive BNP, then we have the direct access echo. They go and get the echo done within 2 weeks. And as part of the training, you must have noted it's a full session on interpretation of echo. Lots of GPs do send the patient for an echo, But when the result comes back, it doesn't make any sense because we are not cardiologists. So a good training skill to interpret that result is important. What it essentially teaches is these are common findings. These are some of the abnormal findings when you've got to send that patient to the cardiologist for further treatment. So that is the aim behind it. So I'll just quickly go through a couple of case examples. The first case history is essentially a patient that did not come to the GP but went to the hospital but was admitted as an emergency under the respiratory team because he had shortness of breath. The respiratory team said, yes, fine, we've treated you now with whatever. Go back to your GP, but we'll do some outpatient test with echo. That echo was done in 6 weeks' time, and the patient was reviewed in the outpatient clinic in about 8 weeks' time to then tell the patient, on the echo, you have heart failure. So what I suggest is you go back to your GP and he will refer you to the cardiologist. Or he may up-titrate your ACE or diuretics. The patient came back to the GP. Of course, that GP was me. So I did start on an ACE and a diuretic, and I referred him to the cardiologist. But while he was waiting the 8 to 9 weeks waiting time for the cardiologist, he had another 2 emergency admissions. And so the cost became £10,000. Just take you to the next case history, which is quite simple. This was a 60-year-old patient, again, a past history of hypertension, coronary heart disease, bypass graft, and he presents to me with shortness of breath, with a bit of ankle puffiness, and obviously one of my differential diagnoses would be heart failure, right? So I do the usual examination and do a near-patient testing, which was negative, right? So I say, right, he can't have heart failure in spite of his history. So I treated him for a viral-induced wheeze with some steroid and antibiotics, and within a week, 10 days, he was completely normal and absolutely recovered. But majority of the GPs would have admitted this patient with a SATs of, 91% and shortness of breath, would have been in an emergency admission. Few GPs tell me, but BNP, we can send it to the hospital and we'll have it in the evening or next day. But that's not good enough, because you're going to make the decision for emergency admission there and then when you're with a patient. And doing the point of care testing and knowing that your BNP is negative actually gives you a good level of confidence that you're not dealing with a heart failure here. Obviously, we did the ECG and other bits to exclude. But that is what is required. Now, that is a saving of £4,000. It's not a small sum. I wonder what we should be paying the GP for doing this kind of work. Any answers there? Not £30, I'm sure. I don't think many GPs at the moment, they are passionate about it, but we need to find the right reward, the right remuneration for that GP to walk that extra mile in order to get that kind of savings or efficiency, if you want to call it. The next case is just the opposite of that, where similar kind of story, BNP near-patient testing was positive. What you will note that even for an echo in the acute trust through Choose and Book, which we all use, don't we? It was 60 days waiting time. So here, again, BNP positive, did the echo, which was positive. He's now waiting. The up-titrating was done. He's waiting for an outpatient appointment. That will be only £200. So again, you have saved roughly £4,000. Very quickly, I've just got 3 more slides to go, I think. AF. And this is the most important slide to my heart. And I think that's the picture nationally. That 40 to 50% of patients with a CHAD score of 2 or more are still not on an anticoagulant. And they are the key people who need to be on it, because they are the ones who are going to develop stroke and cost you hundreds of thousands of pounds. But we give the excuse, and even the consultants, is elderly. If you look at it, it's between 75 to 90 are the key big ones who are not on it because they are liable to have a fall and so on and so forth. Let me put them on an aspirin or a clopidogrel they are placebos, they are in fact more dangerous than warfarin, and you should change. And part of our team and upskilling is that these GPs will hunt these AF patients, up-titrate, make sure that they have counseled the patient, and start them on warfarin. We use the GRASP AF tool. I do not know if anyone is using the GRASP AF tool here, but that is what can run on your system, and it comes out with a full kind of graph to tell you which are those patients that are on warfarin, which are on aspirin, and which ones should be on an anticoagulant. And then you can go to each of these patients and target them. So, the current outcomes in the last 3 quarterly data that I got, this is the current. 117 AF patients were reviewed, 46 initiated on warfarin, 13 were opportunistically diagnosed, so there were new AF patients diagnosed at the same time. New oral anticoagulants, we referred 13 patients. Maybe they were not suitable for warfarin because of whatever the issues may have been in the past. And more ECGs being done in-house, outpatients referrals saved, and emergency admissions. I mean, that's the concept in a nutshell as to how you can use these kinds of methodology to actually get your productivity, if that's your end goal. But you can't achieve that if you don't address the first 3 letters of the word QUIP. And that's the key. Whether you be managers or senior directors or GPs, you've got to get into that level of things in order to deliver. I know maybe I don't have much time for questions, but happy to take any if you want. Thank you.
Okay, thank you very much. We do have a little time for questions. So here's somebody who's actually proved you can do it. Any questions? At the front here.
That was really interesting. And speaking as a GP on a CCG, I think cardiology is ripe for a QUIP. We're trying to do something similar in Mid-Essex. I'm interested in the detection of atrial fibrillation. I saw the tool helps you kind of risk stratify. You can actually try and identify the ones you haven't picked up.
Yes.
Because that's really interesting, because it's catching that.
Exactly, because
population.
If you looked at, I showed you the graph, which is the prevalence of AF, a steep curve. So a lot of those practices that are at the very bottom, why is it that they have low prevalence?
Exactly.
Is it because they are already diagnosed but they have not coded on the cough? That's one reason. Other reason are they are being missing it. Or because many of the AF presentation are asymptomatic. Yes, you have a bit of an irregular heart, that's fine. So what we do is these GPs who have been trained and upskilled, they do targeted screening. So we get paid 30 quid even for diagnosing a new AF patient. So there is a less, but importantly, they have been told that in their flu clinics, in their national health checks, they have to ensure that they do targeted screening, especially in the age group 70 onwards, with a pulse. Pulse is good enough, but there are also other equipments. There are some blood pressure monitors that if you're doing regular blood pressure, I think it's with it's Watch BP Office, I think, is one of those equipments where you can just, it costs about £100, and while your nurse is doing the blood pressure, it actually takes the rhythm of the pulse, and if the patient has AF suspicion, it will flag up on that. So it's either the pulse or using one of the new gadgets.
There's one over there. Yes. Oh, there's one here first. Okay.
Robert Treharne-Jones from INR Star. It's a recurring theme that although a number of our colleagues right across the country are downloading GRASP AF and using it to generate this important data, it's not actually changing clinical practice. Do you have an answer to that?
Well, I gave you the answer in my first 2 opening slides, which is that just telling them is not going to achieve anything. So you've got to have that mechanism of peer pressure, peer review, and it's got to be the whole gamut. Just telling them is not enough.
And there was a question down here.
very interesting to see that though there was
Sorry, I can't hear you.
It was very interesting to see, though you saw a pro-BNP positive, it took 4 weeks to get the echocardiogram. Is there any way to speed it up? That's the first question.
No.
The second question is this instrument where you can do a bedside testing for all these tests. How much then would it cost a GP to have it?
Oh, the last part I don't know, because that depends upon how your CCG stroke, the commissioners, want to fund it. But at the end of the day, the savings is huge to be made, and bedside testing can be done in the same way. This machine is so portable. If you go and have a look at the stand, I carry it in my briefcase. So you can do it on the bedside.
Okay, there's one more question at the back. I think we've got time for just one more.
Hi, I'm Andy Steen, a consultant in acute and renal medicine in Coventry. We see a lot of patients with subdurals and GI bleeds, etc., on warfarin. And one of my concerns about putting the frail elderly on warfarin, that's quite easy, but how is the risk-benefit of warfarin followed up in your patients, I guess is my question, because it may change.
I think the right answer to that would be the incidence with aspirin and other drugs as well, as to what is the rate of cerebral hemorrhage bleeding on those patients who are on an anticoagulant. That risk is not going to go away. And I think over and above the CHADS-2 score, if you've done the CHADS-VASC and has bled scoring, then of course that is a tool you could use. But it's not about not giving them the anticoagulant. It's about mitigating the risks. So if you get GI bleeding, make sure that you have given protective drugs, PPIs, to protect that. But in terms of cerebral hemorrhage, my answer to that would be maybe the newer anticoagulants may be more beneficial, because I think that the newer anticoagulants have shown that the rate of cerebral hemorrhage is much more less and reduced than compared to warfarin.
Thank you.